Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Brooke Trainer, co-host, and today I have Dr. Diana Mosquera and Dr. Patricia Mack with me to discuss Medicare's new alternative payment model, Transforming Episodes of Accountability Model, otherwise known as TEAMS. This is a new value-based care opportunity for anesthesiologists that will be rolling out in the new year. So I'm looking forward to learning more. Before we jump in, can both of you take a moment just to introduce yourselves to our listeners? And please tell us a little bit about your connection to the topic. And we'll start with Dr. Mosquera. Can you give us the big picture overview?
Sure. I'm Diana Mosquera and currently serve as Executive Vice Chair for the Department of Anesthesiology at Long Island Jewish Medical Center, which is one of two flagship hospitals for Northwell Health, a 28-hospital health system in New York and Connecticut. In this role, I collaborate with our division chiefs, perioperative and hospital leadership, and assist in managing and directing all anesthesia services for the department. I recently transitioned into this role. Prior to it, I served as Associate Medical Director and Assistant Dean of Healthcare Strategy at Albany Medical Center, Level 1 trauma academic hospital, serving about 25 of New York State's 62 counties. And there, my primary areas of focus were value-based care programs, both in the hospital and ambulatory settings. So my connection to CMS team comes from a deep interest and understanding of how alternative payment models work on paper and, when they're written into policy, and also how to strategize for their implementation in the wild once they're rolled out in different care settings. I also serve alongside Dr. Mack on the ASA Committee on Economics, within which I chair the alternative payment subgroup. And one of our focus areas is to help anesthesiologists understand alternative payment models and leverage this understanding as they deliver high-quality care in partnership with surgeons and hospital leaders, which is what brings us to today's conversation.
And Dr. Mack?
Thank you so much. I'm so happy to be here to talk about this evening. So I am my department's Vice Chair for Patient Safety and Quality Improvement. And I've served several roles for the ASA, including the Committee on Quality Management and Departmental Administration and some others. And I'm currently Section Chair for Professional Standards. I have a longstanding interest in healthcare economics. I majored in economics in college and wrote my thesis on DRGs many moons ago. And it followed closely throughout my career about healthcare economics and programs such as this. But my specific connection to this really lies in my interest in coordination of care, quality improvement, quality metrics, and how anesthesiologists can contribute to coordination of care from preoperative assessment and optimization through discharge planning. This is something that I'm very interested in my own institution, and I have taken a role for my institution in assisting the New York Presbyterian Health System and Weill Cornell Medicine in coordinating with the anesthesiology departments to optimize our contribution to the team model for our institution.
So Dr. Mosquera, maybe you can start us off with, what is TEAMS exactly?
Sure. So TEAMS is a 5-year mandatory bundle payment model under traditional fee-for-service Medicare. It's a national model, so it includes 740 hospitals approximately, or about 25% of core-based statistical areas in the U.S. It is set to begin January 1st, 2026, and it ends December 31st, 2030. As you know, under traditional Medicare, hospitals and clinicians are paid from separate buckets, generally speaking. Hospitals from the Part A bucket and clinicians from the Part B bucket. A bundled payment model sets a total cost of care target, which is essentially a budget that includes amounts paid under Medicare's Part A and Part B for specific care episodes. Payment for anesthesia services comes from Medicare Part B, and thus in this model would be included in that total cost of care calculation. It's also important to note that under this model, hospitals and clinicians will continue to bill and receive payments for their respective services as they would under Medicare fee-for-service schedule. Medicare does use prior spending trends to calculate a target, which is the equivalent of a budget for the program year. At the end of each calendar year, Medicare then calculates the total payments made for each episode category and then determines whether the hospital went over or under budget. It also looks at whether the hospital met certain quality measures and adjusts those payments accordingly. And ultimately, depending on the level of financial risk that the hospital is exposed to, this model has 3 different tracks of risk. Medicare either issues a payment to the hospital or the hospital is potentially responsible for a repayment back to CMS.
What problem is CMS trying to solve with this? I'm just curious what the goals of this new alternative payment model are.
Yeah, that's a great question. And from a historical context, I think it's always important to just kind of go back and think through how we've gotten here. And so this is the 7th iteration of a bundled payment model since the passage of the Affordable Care Act, or ACA. The overarching goal for this model is the same as when CMS developed its first bundled payment model when it came up with hospital payments under the DRG system. So DRGs stand for diagnosis-related groups, which are essentially used to describe patient acuity. So how sick a patient is, and there's different DRGs for different types of diseases or disease categories. CMS then takes those DRGs and calculates almost like an index that helps them adjust for how sick the patients are that are going to that specific hospital. And then that index is then used to adjust the payments that CMS sets every year for hospital services. So CMS is essentially trying to control the cost growth trend by setting these budgets up front and also transferring financial risk for going over budget to hospitals. So overall, I view this model almost as a rough extension of the DRGs, because in the DRGs, CMS sets up payment amount every year for hospitals. In this case, CMS is essentially adding on that part that it would pay clinicians, and it's calling it a spend target. So the goals for this model are to reduce care fragmentation. It includes a requirement to hand off care to primary care, as well as a focus on post-acute care transitions. And overall, it defines success as reduced recovery time, reduced utilization of healthcare resources that can be avoided, as well as reduce readmissions and reduce ER utilization for patients.
Okay, great. And who is going to be impacted most by this new TEAMS model, and what surgical episodes?
Directly speaking, this will impact hospitals because it ties the risk back to hospitals. So it'll impact hospitals as well as hospital outpatient departments. It's important to also note that in the cost calculation, it also includes the 30 days after discharge from either the inpatient admission for a specific case or that outpatient procedure. And those DRGs that are included can be found on the CMS website, and I believe we also have it listed on some of our ASA publications. And it focuses on 5 episode categories, including lower extremity joint replacement, surgical hip and femur fracture treatment, spinal fusion, CABG, and major bowel procedure. And for each of these, CMS has published the DRGs that are included in each bucket.
And this is starting January 1st, I think I heard you say. So, Dr. Mack, what do you think is going to be the implementation of this? What is that going to look like for anesthesiologists at the ground level?
Well, I think that is going to be very variable across different types of practices and different institutions. I think that it depends somewhat on your relationship with your hospital leadership, whether or not you work for the hospital, you're an independent group, or an independent anesthesiologist, an academic medical center. From my experience at Enterprise, which has both 2 academic medical centers and various other types of hospitals, including hospitals in distant suburbs, community, urban hospitals, etc. What we're trying to do is focus on the big picture in terms of outcomes, and where an enterprise or a hospital can provide structure and guidance to allow each individual type of institution and departmental relationship to formulate a bit, not really their own plan, but you cannot make widespread implementations the same in different kinds of institutions necessarily. So we're working both with the overall healthcare system, but also with each specific type of surgical subspecialty. For example, coronary artery bypass graft. The cardiac surgeons are working both across the enterprise, but also within each of their individual hospitals, along with preoperative assessment teams, preoperative optimization teams, and primary care physicians across all the subspecialties in each of those areas to formulate plans that we're going to be able to coordinate care, optimize patients before their surgical episode when we have the time to do so. Obviously, with hip fracture, there's probably not a lot of time to do that, but also ensure that ERIS protocols are adhered to. We try to minimize the use of opioid anesthetics, encourage early bowel function, early ambulation, all the things that we know how to do so well. And we have been doing, for more than a decade as anesthesiologists and leading those processes in our institutions. And then the part that's we may be a little bit less involved with, unless the critical care teams are going to get involved, is discharge planning. However, if we are amongst the first people to see the patients in terms of optimization or preoperative assessment, we are able to assist the entire team in setting expectations for patients about discharge planning, encouraging them to set up expectations that it's best to go home with support when at all possible. It's really been fascinating for me to learn about all the systems in place in hospitals that do exist to help patients get home rather than to subacute care, and the home with assistance programs that I didn't even know about before starting to meet about this program. But as we set the tone for our patients in terms of their expectations about their pain management, we can certainly contribute in the area of expectations for discharge to home along with the rest of the teams.
And is this something you think that all anesthesiologists should be participating in? Why or why not? I'm just curious.
This is going to be applied widespread across the nation in many, many institutions. And I think that most of us are going to be touched by this in the coming year. I expect that a lot of anesthesiologists don't even know about this because at this point, in the first year of the program, there's not going to be any direct penalty to or reward for anesthesia groups. I think that the best way that we can get involved is really in collaborating with the hospitals with which we work. I think it's a little bit different between hospitals that have really participated in joint bundle payments in the past. They have experience with this, and probably their anesthesiologists are used to being involved with that. So I think that it's something that we need to know about. Something that I've emphasized in the past to groups that may not be invited as much to be involved by their institutions is the recognition that all groups have services that they provide to institutions for which they are not directly paid by insurance corporations or by Medicare. And those services, such as preoperative admission clinics or preoperative testing areas, sometimes acute pain services, other things like that, ICU care, may not be completely paid for by any kind of official reimbursement. And so there might be some compensation that is provided by the healthcare institution directly to the Department of Anesthesiology. And it's in these areas, these things are often negotiated and renegotiated on an annual basis. They can form the basis for, some contract or new contracts issued to anesthesia groups. And so anytime that you're able to demonstrate to the hospital in which you work the value that you provide above and beyond just simply providing anesthesia care in the OR, which is, of course, the basis of what we do and critically important, I think that really provides a win-win situation, both for the anesthesiologist and for the patients that we care for and our institutions.
I think you brought up a really good point about, the appropriate recognition, whether that's financially or, and, just having a seat at the table. But how can you suggest to anesthesia practices, can they work with their hospital executives to ensure they get this appropriate recognition? I mean, there might be some additional payments or recognition available if they could figure out, how to do that.
I think it's going to be very variable depending on where you work and what the existing relationship is, depending on whether you're a hospital employed or independent group or academic group affiliated with the institution. I think that many of our groups already have developed programs such as a perioperative surgical home in the past. And so there's been coordination of care, and there's already been a recognition of the contributions that we make overall to the patient's entire episode of care. And I think that these things have to be reemphasized in the setting of team. I believe that most hospitals are gearing up and forming working groups to try to address some of the challenges that the team program is trying to address, such as care transitions and care processes, and ensuring that higher value care is administered to and available to the patients. And so I think it's really just leveraging those relationships that already exist in many institutions, or else pointing out to whether it's a CMO, a chief operating officer, even director of nursing, and to the chief surgeons or chairs and the departments that are most directly impacted, to offer your services, offer your advice, and offer to collaborate with them and see where you can find increased value for the patients as well as increased value for the institution.
Dr. Mosquera, do you have anything to add in that regard?
Yeah, a lot of these, if you look at these 5 surgical episodes, they're all episodes where we have done a tremendous job over the years around early recovery pathways. And so, similarly to how the models themselves have been iterative, I think that this is an opportunity for anesthesiologists, regardless of where they are on the spectrum of collaboration, to get engaged, whether it is sort of dipping their toe in by saying, let's really start to formalize some more robust ERAS pathways and taking advantage of this and how this can align with the hospital goals. And that can allow you to potentially get some resources, some additional help to help you stand up programs or access to data. And so either way, I think that the right approach should be to use this as an opportunity to expand and build on whatever your institution and anesthesia group has participated in the past.
Yeah, you got to find what makes them tick to get that seat at the table and have those conversations. And I just want to turn back to the implementation of the model for our listeners. So, Dr. Mack, is there anything that keeps you up at night when you think about this? And I'm curious how you expect it to impact quality and the metrics.
Right. Well, the quality metrics that are going to be tracked are hospital readmissions, which I think sometimes anesthesiologists feel somewhat removed from as a metric. It's definitely something that I've never really thought about when I'm providing an anesthetic in the operating room. And this is hospital-wide all-cause readmission rates. But when we think about how we can prepare people, these are big cases that they're looking at. Joint replacements, CABG, major bowel surgery. These are patients who often may have, except for the outpatient joint replacements, outpatient spinal fusions, they'll have several days of care in the hospital. So, for example, in spinal fusion, if you're really looking to reduce opioid use, say you've added a ketamine infusion, you're trying to do whatever you can to make sure that the patient will have good bowel function, be up and walking the next day, not be hindered by longer term effects of either pain management or their anesthetic. This is something I think we are not always the best at communicating in terms of thinking post-op day 2, post-op day 3, and then getting them ready to go home and making sure that everything is in place. We think about adding in post-operative regional nerve blocks so that the patient may have longer lasting pain control in the days immediately after an operation. These kinds of communications are something that we don't really think about traditionally in the longer term. Like, what is the impact on readmission if patients are able to get their physical therapy better in their first few days after care? Will that impact whether or not they are discharged to a skilled nursing facility or to their home? The reason why I keep bringing up the skilled nursing facility, it doesn't really show in the superficial read of the program, but when you look at the cost of care of an episode, and this is obviously going to be episode-based cost of care averaged over time, and the costs, I believe, Dr. Mosquera can correct me if I'm wrong, are from 2022 to 2024 are the baseline costs for your institution for these episodes that are going to be used as the comparison level of cost. And they're going to be risk-adjusted costs and also adjusted by the economic status of the community in which the hospital serves. But one of the greatest costs of care in the entire 30-day episode is when a patient is discharged to a skilled nursing facility as opposed to going home. And so I don't think that we are used to necessarily thinking about how our intraoperative and immediate postoperative care may impact their ability to get their physical therapy, to get their social work plan in order for them to go home. That will make a big difference overall in the cost. And in fact, in some instances, it is the biggest cost adjustment that might be focused on by your institution. Patient safety indicators are another. PSI 90s. It's a composite score, and this is going to be one of the quality adjustments made retroactively to the determination as to whether or not you get a bonus reimbursement or you get a penalty. And so the things that we can impact in PSI 90 include reintubation rates, PSI 11 and 12 reintubation and occurrence of DVT, where we're definitely involved in those things and in making sure that our patients have appropriate DVT prophylaxis and that, our plan for extubation at the end of a procedure is appropriate. The biggest thing that keeps me up at night, though, of the quality adjustment metrics is the patient-reported outcomes. I feel like this is a real challenge, and I know that Dr. Mosquera has experience with this and with the joint bundles, but I find that getting meaningful anesthetic patient-reported outcomes very challenging. I recall that in my institution, we used a well-known patient experience survey for a while, and the question was your anesthesiologist friendly? And we really need to sort of up our game in terms of patient-reported outcomes when it comes to anesthetic care if we want to find something to really contribute to this metric.
Is there anywhere that our listeners can go to find these quality adjusted metrics? Are they posted anywhere?
On our ASA website, if you go to asahq.org and you go under practice management, you should be able to access the alternative payment model subsection. And there we have included links to this model as well as prior ASA Monitor articles that have been published specifically outlining this model.
That's great. And the last question I have is I understand that this is a 5-year model. So what do you expect to see in the coming half decade? Is there anything that anesthesiologists should know or do as it's rolling out?
I definitely foresee more expansion into this sort of world of surgical bundles by CMS. I think that it makes sense for CMS to think about, evolving to just having this cost of care paid upfront, as opposed to having this two separate sort of payment streams from Part A and Part B for these, especially as they get more facile with data and potentially even deploy AI to try to do some, advanced analytics and predicting of how the cost may end up. And this also would capitalize on the fact that most physicians and most clinicians are now employed in employed models or integrated into hospital systems. And so that would really align those hospital-based specialties even closer with hospitals than they are already.
Dr. Mack, do you have anything to add to that?
I think what I see happening in the future is actually an increase in the coordination of care and perhaps a real increase in our role I think that it's an opportunity for us to review what was done recently and established by the Center for Perioperative Medicine, because a lot of the things that they're focused on, I think would be very useful in terms of what an anesthesia department could do to help their institution with the implementation of this model. Just sort of the overall taking the patient from the time of surgical booking through the 30 days of care. Obviously, we're not involved directly in every step of that, but I think that our awareness and our ability to contribute to a good outcome for those patients will be much different 5 years from now than it is currently.
I think it's really interesting. The groups that they chose are, those higher risk patient populations that are your typical elderly populations, Medicare populations. I don't know how this would play out for commercial payers, for example, but in the transition to home, you mentioned about that home with assistance. Right now, the transition home from the hospital is setting up home healthcare agency. They get out there in a couple days. But if they could figure out a way to get home healthcare agencies to see patients, the same day or the very next day after surgery and have that be more streamlined, you could see that this could be the future of getting people home faster so they don't have to go to nursing facilities or stay in hospitals longer. So partnering hospitals with more home healthcare agencies for that transition to be more smooth. They follow these protocols. They're involved in the protocols. I think that could be really great for patients.
And I think the ultimate goal is really for that to start before they come in, for those episodes that are able to do so.
Yeah.
Which not all of them, but that the home health is established before.
And that's actually a really great point, because this model is different from prior models that were also bundles, and that prior bundle payment models were 90 days. This is really 30 days, and it's specifically because CMS is looking to incentivize a more cost-efficient / quality transition back to home, and to have patients go back to a place where it's at the lowest care setting where they can still get high quality care. So in this case, it would, as you're mentioning, it would be changing the mindset from having everyone go to skilled nursing to upstream of that, right? Can you go home with home PT, or can you go home with some services, or visiting, VNA or home health aide?
Yeah, exactly.
And one other point is that the cost of preoperative optimization is not included. The bundle starts the day of admission for the episode of care. So we have an opportunity, if we were in a situation where we could be paid for those services in Part B Medicare, which, may not be common, that those costs will not be included in consideration in the total cost of care. So the institutions may emphasize the pre-op optimization more than they do now. And I think that we could have a very vital role to play in that. Maybe not doing all the optimization ourselves, obviously, but in coordinating between prehab for physical therapy, smoking cessation, anemia management, preoperatively, things that in some institutions anesthesiologists do quite well. But if all that work is not included in the cost, it may be that hospitals actually might emphasize it more, because it can have potentially cost savings later on when the patient is more optimized, their hemoglobin is optimized. They've done some minimal prehab work to prepare for their joint replacement. Their outcomes, in theory, will be better.
Exactly. Yeah, that's great. This has been a world of information. Thank you both so much for sharing your expertise with us today. And I think you said it earlier that I'm sure a lot of us anesthesiologists didn't even know this coming. So it's great to have this information out there. And so for listeners who want to learn more, visit asahq.org/quality-and-practice-management/team. And please join us again soon for more Central Line. Thank you both for joining us today.
Thank you so much.
Thank you.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and welcome to my first Monday Morning Minute. Today and each month, I'll provide you with a few highlights from the Monday morning outreach. First up, a member benefit. ASA is working to provide value, and so I'm pleased to share that we have launched a new member-exclusive insurance program. This program will be particularly attractive to locums anesthesiologists and others without easy access to group policies. Next, helping our communities is important. During Anesthesiology 2025, we hosted our 9th annual Doctors Back to School event, where 80 middle school students heard personal experiences from ASA members and then participated in hands-on stations, including intubations, CPR, and epidurals. Sounds like they might be the answer to some of our workforce challenges. And lastly, congratulations to the Louisiana and West Virginia components for winning the 2025 Membership Reengagement Initiative. We're excited that ASA has reached a record number of active members and total membership, which now exceeds 60,000. Well, that's all I have for today. But thanks for listening, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach. Until next time, this is Dr. Patrick Guillaume, your ASA president.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. Every day gives you new reasons to say yes to ASA. Explore all member benefits, renew now, or join today at asahq.org/benefits. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.